Mark Tai, and I am one of the OMM faculty at OSU CHS. I will be presenting this faculty development and grand rounds presentation on the 5 Ws and an H of osteopathic recognition. The intended audience for this presentation is quite wide, including pre-med to pre-med faculty counselors to medical students, residents, and clinical and non-clinical faculty. The objectives are going to be discussing the 5 Ws. What is osteopathic recognition? Why do we have osteopathic recognition? When did osteopathic recognition start? Who is impacted by osteopathic recognition? And where are these programs with osteopathic recognition? And how do we implement osteopathic recognition? Before we start about the what, we need to kind of start back with the why. Why do we have osteopathic recognition? When did this start? Before 2015 to 2020, we had two residency credentialing bodies, the ACGME and the AOA. Graduates from the MD school or the DO schools had options of attending either of these. The MDs could attend a residency program of the ACGME or a dually accredited program where they certify both or meet the requirements of both the ACGME and the AOA. If these MD residents choose to continue from the ACGME towards a fellowship, they can also have the same options of ACGME or dually accredited. Now, the dually accredited is in smaller font because the availability and opportunities for dually accredited fellowships are quite limited. There aren't as many AOA fellowships, and adding to the limited residencies, fellowships. The DOs, on the other hand, have the opportunities to enter ACGME, AOA, or a dually accredited residency programs. Okay. If they enter the ACGME, they're very similar to the MDs. They could choose to go towards the ACGME fellowship or the lesser or limited option of the dually accredited. If they had attended the dually, they have the options of attending any of these fellowship opportunities. If they attended the AOA program, then they are mainly restricted to AOA type residencies, so AOA fellowships or dually accredited fellowships. Now this slide is very, very busy, and there's a lot of options and way to navigate. If you did a traditional school or traditional year at ACGME versus AOA, there's just a lot of combinations that could happen. The 41 accredited college of osteopathic medicine in the United States. These colleges are accredited to deliver instructions at 66 teaching locations in 35 states. In the current academic year, these colleges are educating more than 35,000 future physicians. So 25 to 35% of all U.S. medical students are DOs. 7 of the colleges are public, while 34 of them are private institutions. The growing number of osteopathic medical schools and osteopathic medical graduates was one of the factors contributing to the single accreditation of ACGME. So during this transition period of 2015 to 2020 to the present, all the residency programs, ACGME, dually accredited, and AOA, were now under one umbrella of ACGME, meaning that both DOs and MDs have equal opportunities towards the residencies and fellowships. The ACGME created the osteopathic recognition to formally acknowledge the ACGME accredited residencies and fellowship programs that integrate formal education in osteopathic principles and practice in curriculum consistent with the osteopathic requirement. So residents or students from the MDs and the DOs have pretty much an option of going to an ACGME or an ACGME with osteopathic recognition. Okay. Same thing with proceeding towards ACGME or OR with OR. Now, one of the benefits of this is that there's a uniform GME accreditation, meaning that you don't have to abide by the AOA or ACGME. You have one universal standard for all the specialties. You have reduced costs and increased efficiencies. So essentially less work with not having to do double the accreditation paperwork, and opportunities for all medical school graduates to receive formal osteopathic medical training during residency fellowship in programs with osteopathic recognition. So regardless if you attended a DO school or an MD school, you have the opportunity to continue or receive your osteopathic medical education. Now, what is considered the osteopathic recognition? The osteopathic requirements or the requirements for osteopathic recognition includes submitting an application to show how osteopathic principles and practice, or OPP, and OMT is integrated into the curriculum. This QR code will take you to the ACGME osteopathic recognition requirements. Now, some of the definitions we should discuss before we move on to make clear that some of these are not as synonymous as we think. OPP stands for the osteopathic principles and practice, and it's more of a conceptual and practical understanding of the distinct behaviors, philosophy, and procedural aspects of osteopathic medicine. Where OMM, the osteopathic manipulative medicine, includes the diagnosis of somatic dysfunction and treatment using osteopathic manipulative treatment. So OMM is more the hands-on modality of both the evaluation and the treatment. And OMT is the treatment portion of it. Okay. The indications for OMT is considered the somatic dysfunctions, where you're able to evaluate and find the presence of one or more of the following physical findings of tenderness, tissue texture abnormalities, asymmetry, or restricted to range of motion. Now, when the osteopathic recognition initially came out, there was a misconception that the residency programs had to integrate more OMT or the hands-on treatment modalities into the curriculum. In reality, the stress was that it was more OPP, or osteopathic principles and practice, accounted for a majority of the time. For example, how the 4 tenets are used throughout the curriculum and patient care. OMT is only a small part of the requirement, and to the extent that is applicable to the specialty. Okay. Meaning that if I had a otolaryngology physician, they are not expected to perform OMT to the lower extremities. However, they would be expected to be proficient in OMT of the head and neck. Okay. So, a review of the 4 tenets of osteopathy, the first one being the body is a unit. The person is a unit of body, mind, and spirit. An example of this is a patient presenting with chronic pain is treated not just for the physical symptoms using OMT to address the musculoskeletal issues, but also with the understanding of their emotional and psychological health, perhaps offering support for stress management, counseling, or addressing underlying mental concerns. Another example where the body as a unit is viewing how the organs are not independent to each other. For example, the functions of the heart are not exclusive to the heart, but can also affect other organs such as the kidneys. The second tenet is the body is capable of self-regulation, self-healing, and health maintenance. An example of this is a patient with a common cold is encouraged to rest, stay hydrated, and manage symptoms with supportive care, trusting that the body's immune system will fight off the infection without the need of antibiotics unless complications arise. Now, the extent of the self-healing is the body's resource or capacity resource. For example, a cut can be healed properly, but if a person lacks the clotting factor, then the healing can be compromised or quite delayed. Another is a person with chronic conditions may also have difficulties with self-healing, self-regulation, and health maintenance. The third tenet is structure and function are reciprocally interrelated. An example of this is looking at the function of the spine or the structure of the spine and the red blood cells, where altered mechanics of the spine can impair the nerve function, blood flow, musculoskeletal health, and then leading to pain. So you have a normal spine that has an optimal alignment, and then you have a scoliotic spine where there's a lot more stressors spread out, not just within the spine, but through the pelvis, the lower extremity, the head, neck, upper extremities, that it has a ripple-like effect throughout the rest of the body. Okay? And their functions becomes altered. With the example of the red blood cells, where their normal function and their normal shape is this biconcave structure, enabling it to transport oxygen from the lungs to the tissues. However, with conditions that distort the structure, such as sickle cell, it changes the functions where the oxygen's no longer able to, or the red blood cells no longer able to transport the oxygen that's needed. The last tenet is rational treatment is based upon the understanding of the basic principles of body unity, self-regulation, and the interrelationship of structure and function. Basically, rational treatment is based on all three of those principles. If I had a patient with asthma, I would consider using OMT to help improve the chest mobility and diaphragm functions, such as doing rib raising, while complementing the conventional treatments such as inhalers or bronchodilators to enhance the body's respiratory functions and overall well-being by supporting the body's natural healing process. Now, how do we implement this osteopathic recognition? Now, for some of these programs that have started out as osteopathic programs under the AOA, it's more of a continuation of what they have continued or what they've done in the past. What other programs, as they're initiating it, need to show is that the program has an osteopathic clinical learning environment where both the faculty and the residents give and receive the education. The main part with the osteopathic clinical learning environment is that you have a osteopathic champion, or in this case, the director of osteopathic education, who is in charge with the designed supervisions and integration of OPP into the curriculum and OMT into the curriculum. The other necessity is having an osteopathic faculty member aside from the Director of Osteopathic Education, or the DOE. This osteopathic faculty member is important in also being able to support the DOE in their commitment to teaching osteopathic principles and philosophy and how it's integrated into the patient care. And last, the education is the not only just the OPP, but how OMT is applied to their specialty. The other leg of the osteopathic clinical learning environment are the resources. What resources are needed or available to help teach and educate the learners? So are there hospitals? Are there learning facilities, clinics, simulation labs? Are there OMM labs or OMM tables available for OMT to be performed? Are there experts to help support scholarly activities, such as librarians or statisticians? Are there time available for the learners to devote towards research or independent studies, or dedicated uninterrupted didactic times? The other leg of the osteopathic clinical learning environment is the assessment. We have the education, we have the resources, but we also need a regularly checked assessment or evaluation to see, are we meeting our goals? Are we teaching what we plan on teaching? Are we learning what we're planning on learning? So the assessment involves a review of all the information of the residents, the faculty, the programs, from a 360 view from patients, staff, faculty, co-residents, and assessing at meetings, regular intervals, the milestones, the progress of the learners. In the osteopathic clinical learning environment, we're looking at their integration of OPP into their patient care, and also their proficiency in performing and using OMT in their for their patients. Other avenues of evaluations include the OSCEs, which are kind of like an objective structural clinical exam, or like a mock physical exam or mock simulations, where you have a standardized patient and your learner would go through that situation as they're being observed, and you can assess their interactions, their knowledge, and their skills, procedural skills during that encounter. Now, all these legs for the osteopathic clinical learning environment work into conjunction together, okay, as the assessments help the level of education, and education feeds off of the resources. They're all interconnected together. Okay. But once we have this osteopathic clinical learning environment, how do we integrate OPP and OMT? First thing I would recommend is changing our interpretation of what we consider OPP. Often I see in the evaluations the question, does the learner integrate OPP into the patient care? Now, OPP, if we're looking at it, someone who may not understand what OPP means may be difficult to evaluate appropriately if the learner had integrated OPP or not. The other way is if the learner felt they were actually integrating OPP, but the evaluator is looking at it from a different tenet or a different component of OPP. So what would be more helpful would be that we look at it from, does the learner consider the patient's mind, body, and spirit? Does the learner consider the patient's structure and function as it relates to their condition? Does the learner consider the patient's ability to self-heal? The way we look at this OPP is more specific and lets us pinpoint which component of OPP is being addressed. Additionally, the interpretation of the mind, body, and spirit is much more universal in application than did the learner apply OPP. So we can split that evaluation question to multiple avenues of patient's mind, body, spirit, structure and function, ability to self-heal, and other components of OPP. The other avenue of the osteopathic clinical learning environment is the OMT. This is probably where the biggest struggle is, and I'm going to try to address some of these concerns. The main concern I hear is I haven't done OMM in a long time. So how can I address this? Well, some of the options are you can still supervise if you understand the key concepts, indications, and contraindications of the technique. And you only need to be proficient in OMT applicable to the specialty. So you don't need to be proficient in all 10 regions or in all varieties of techniques. The techniques of soft tissue articulation may seem very basic, but have strong evidence and efficacy in helping patients with their conditions. It's easy to understand the key concepts and indications and contraindications of both these techniques. If you want to expand your toolbox a little further into muscle energy or high velocity, low amplitude, or still technique, ligamentous articular strains, cranial technique, counter strained, those take a little bit of practice, but like any other skill, with practice comes the proficiency. Now, how can I teach OMT? Now, OMT is taught like any other procedural skills. You can modify the techniques to teach that you're most comfortable with, and then be able to modify it to the environment that you practice, like the hospital beds, the exam rooms, or the tables, or the chairs in the offices. You can find additional resources by attending OMT faculty development that can be presented virtually with a hands-on component to help complement or give you feedback as you're going through it. Or you can attend some conferences locally, regionally, or nationally that have OMT sessions taught throughout. Look at OMT as a procedure. You can use the EPA or Entrustable Professional Activities scale to gauge their progress on that particular procedure. For example, if I had a patient come into the emergency room and needed a lumbar puncture, and the learner wants to do it, I would ask, what can you tell me about the lumbar punctures? What are the key components, key highlights, the indications, contraindications of the lumbar puncture? If they're not able to articulate any of this to my level of comfort, then I will have to do the lumbar puncture. If they were able to explain some, but still missed quite a bit of the key components, then I'll help out quite a bit. And then less and less where I helped out a little bit, or I didn't need to be there, or I needed to be there but did not help, to I didn't need to be there at all. Okay. This shows that the learner is very proficient, has done this procedure multiple times, and does not require supervision. Okay. When it comes to OMM or OMT, a similar example is if I had a learner who just saw somebody with low back pain or neck pain in their office, I'd ask, and they're considering doing OMT for the patient to help with their pain, I would ask, well, what can you tell me about doing soft tissue for this lumbar region? What are the key steps, the indications, and contraindications? If I don't feel that they're comfortable with doing the procedure, then I would ask them to go look up that procedure and watch me perform it. And the next time, hopefully there wouldn't be as much assistance and they would progress longitudinally. So my ask of you is for the next 5 patients for the remainder of the day is to look to see how have you been integrating the OBP, their mind, body, structure, function, self-healing, and even considered OMT in this patient encounter. Okay. Overall, how have you been integrating OPP into your practice? Because I have a feeling we are already doing it, but are challenged with actually stepping back and realizing how we're doing it and how we're able to articulate this to someone else. Now, I hope that as I was going through the components of the osteopathic clinical learning environment, you recognize that it is not 2 different sets of responsibilities or 2 different hats that you have to wear, when in reality, you're the same person who practices this patient-centered care. Okay. Some view just the ACG me and the 2 hats of the ACG me and the OPP, when in reality, it is one person, same person who practices with patient-centered care. Residents with osteopathic recognition incorporate osteopathic principles in practice in addition to the standard ACG-ME core competencies. Okay. You still have the same 6 core competencies: patient care, medical knowledge, professionalism, system-based practice, regardless of the ACG-ME or ACG-ME with osteopathic recognition. The difference being that you have additional standards of core competencies for osteopathic principles. The difference that I find the most challenging is being able to articulate what we do, how we do it, and what we do is articulate how we do what we do as osteopathic physicians when it has been ingrained in our patient care philosophy. So how we consider the small details in our medical decision making of why we chose one antibiotic over another, or considering the factors of the patient's ethnicity, age, socioeconomics, etc. The osteopathic principles and philosophy is not exclusive to osteopathic DO physicians. All medical physicians can practice OPP. It just happens that this is how we label and describe this philosophy and principle. Both types of programs provide comprehensive clinical training, but the key distinction is the integration of osteopathic principles and osteopathic recognition residencies. Where are some of these programs with osteopathic recognition? There are currently about 274 programs scattered throughout, and majority of them with family medicine and internal medicine. And you can see them also spread out through other specialties: orthopedic surgery, pediatrics, cardiology, ENT, and anesthesia, for example. Okay. Within Oklahoma, where both the OSU and OMICO, we have 17 osteopathic recognition programs. I split them into kind of three categories, where you have cardiology, 3 internal medicine programs, 7 family medicine programs, 1 internal medicine, pediatrics and psychiatry, surgical programs of general surgery, OBGYN and ENT, and other such as interventional cardiology. Okay. Now, who are impacted the most by osteopathic recognition? If we look at the NRMP match data for this academic year, we see that the total of internal medicine, family medicine, and pediatrics, or primary care positions, have a match rate of 52.2%. And that 867 DO seniors participating in the SOAP, and 526 accept positions. Overall, an increasing match rate of 92.3 and a placement rate of 98.5. So we have a growing list of osteopathic graduates. As this osteopathic recognition is still a new accreditation, the value of it has been proposed that it's promoting the general good of osteopathic medicine. So more GME spots for the expanding UME population, recruiting both MD and DO, extending and expanding the OPP OMT training continuum, promoting holistic patient care throughout the community, and ensuring a seat at the table. So where there's legislations or regulations or protocols or guidelines that an osteopathic physician with the osteopathic philosophy training has a seat and a voice. A marker of quality for program's commitment to teaching and assessment of OPP at the GME level. Now, personally, I've also seen that MDs in osteopathic recognition programs graduate and have better skill sets in musculoskeletals, procedures, or in palpation, because they're just adding that additional tool in their toolbox. Okay. Now, for me, as a graduate of an osteopathic medical school, I'm sure going through 4 years and being taught about 2 years of OMM or OPP, and then entering a residency program, I would think that all the hard work that you got to get into medical school, that and all the time that you spent with OMT and OPP, you would want to continue that, and how much of that is a core value of how you would want to practice. And to be able to continue that type of training throughout your medical residencies. Okay. Now, the future of osteopathic medicine, I would hope, is that there's continued opportunities to teach OPP throughout medical training, where the graduates, osteopathic graduates of some of these fellowships, come back and become academic trainers and further expand the osteopathic expansion. Okay. I would hope that in the future that there are more opportunities to go to medical schools and residencies where OPP is taught. However, if the learner's not able to become or exposed to osteopathy, that them or their family is being cared for by a physician that has the training and components of the osteopathic principles. Now, some of the resources as we're navigating this process can be found at the ACOFP. The QR code will take you to the tool kit with multiple webinars and documents. And if you're looking for where can you find some of these requirements, ACGME has the most current updated and the FAQs with it. If you're looking for where do you find osteopathic recognition programs, one of the resources is the FRIDA through the AMA, being able to filter through the residencies and the type of programs, osteopathic recognition, okay, and through the multiple specialties that are available. Okay. Or you can go onto the ACGME website and look through the public search domain, finding the specialties or by the state, and looking to see which one had osteopathic recognition. If you still have further questions, you can contact me best by my email at mark.ty@okstate.edu. Thank you so much for your time, and if you have further questions, feel free to contact me. Thank you very much.